Hello, and welcome to Healthy Living. I'm Dr. Donald Pelto, and I have a special guest here today, Shannon Place, and we're going to do a little role reversal this afternoon. Shannon is actually going to be interviewing me about a booklet that I put together on plantar fasciitis. Plantar fasciitis is a foot problem that seems like an epidemic today, with a lot of people having different symptoms, and so we're going to go over a few of the common questions about plantar fasciitis and explain a little bit more. Shannon, thanks for joining us.
Thank you for having me. Okay, so my first question is, what is plantar fasciitis?
Okay, so for everyone that's watching, plantar fasciitis is a problem on the bottom of the foot where there's a ligament on the bottom of the foot. And what happens is this ligament gets tight and you develop pain. One of the most common symptoms is pain when you get out of bed in the morning. And so basically, if you put your foot over the bed and you stand up and you have heel pain, we also call it heel pain, we also call it heel spur syndrome. It's a problem where there is thickening or inflammation of the plantar fascia on the bottom of the foot. This area gets inflamed, and it seems like everyone has it these days. That's what plantar fasciitis is. So if you talk and break down the terms, the plantar fascia is that ligament, and itis always means inflammation. So it's an inflammation of that ligament.
And who is at risk for plantar fasciitis?
It seems like everyone, and it might just be my patient base in the clinic, but it seems like everyone these days is coming in with plantar fasciitis. The ones that I find more at risk, though, are middle-aged males and females. So people that maybe are less active and then they get a little bit more active. They might be putting on a little bit more weight, doing a lot of activities on the weekend. They do gardening and different types of activities. These people seem to be at risk. I don't see plantar fasciitis in children. You don't see kids with heel pain. And I don't see plantar fasciitis with the elderly patients. And you really don't see it in the teens or the college students and things like that. There usually is something, usually it's an increase in activity that causes the fascia to get inflamed. And the problem is it never is able to calm down. People may wait weeks or months and see if it'll just calm down. And if it doesn't, that's when they need to seek some help.
And so what are possible preventative measures of plantar fasciitis?
So to prevent plantar fasciitis is a challenge because you don't know if you're going to get it or not. One of the biggest problems that I find is that people, they wear their oldest shoes for their hardest activity. So for example, you're going to go and mow your lawn. And you're going to wear your oldest, most worn-out shoes because it's going to be some work where you're going to get your shoes dirty. And I find that people wearing very unsupportive shoes, they can develop plantar fasciitis. Another thing, I find patients, let's say you're going on vacation, and then you're going to be wearing flip-flops. You're going to Disney and wearing flip-flops all day long. A lot of those people are more prone to developing plantar fasciitis because of the lack of support in their shoe gear. Another type of a group are people that are just starting to work out. So let's say you go to the gym and you made some type of resolution to try to lose weight and you start to do some exercise. And what I find is that people, usually the first couple of days, they don't have problems with working out. But then all the muscles get tight, and specifically the muscles in the back of the calf. Those are the muscles that get tight, and if those muscles are tight, they don't let the fascia work as well. And with that type of a problem, it makes it more prone to developing plantar fasciitis. Those are some of the reasons.
Are there any specific exercise or stretches that you recommend for plantar fasciitis?
Yeah, so in terms of the exercises and in terms of what type of workout you should do to help with plantar fasciitis, most people that come in, they've usually tried something on their own. Most people have tried the runner's stretch where they push against the wall and they try to stretch out their calf. Some people may have tried that stretch where you step on a step and your heel goes down and it stretches your calf muscle. Those are the stretches that most people try. They also may try something called a night splint, which is basically a splint that holds your foot up like this when you're sleeping in bed at night. They'll try all of those stretches before they come and see the doctor. But that doesn't mean that those stretches always work, especially if the area is very inflamed. The stretches may not be sufficient. And I always like to explain what happens is if you think a model of your foot, if you think of the heel, you have the heel here, you have the Achilles tendon right here and the fascia down here. If the Achilles is tight, so is the plantar fascia. So they kind of both pull on that heel bone. That's why it's important for us to work on both the plantar fascia and the Achilles tendon. A lot of the stretches that you'll find aren't plantar fascial stretches. There are certain ones where you can kind of just massage it and kind of lengthen it at your toes, pulling up on your toes. But what works better are the calf stretches.
Now, you mentioned heel pain common in plantar fasciitis. Are there other symptoms of plantar fasciitis?
Mm-hmm. So plantar fasciitis, the most common symptoms that we see are pain when you get up in the morning. It's pain when you get up in the morning. That gets better as you walk. So as things start to stretch out, that pain goes away. And then as you, for example, we're sitting down, now we're going to be sitting down for a half hour to an hour, then when you get up, you would have pain again. So that's the telltale hallmark symptom. But there are different areas on the bottom of the heel where plantar fasciitis can hurt. It may hurt, sometimes it hurts on the inside of the heel, sometimes it hurts in the center of the heel, and sometimes people have pain on the outside, and usually the pain on the outside is because they're walking a little bit different. And so plantar fasciitis, you have to be careful because people come in and they say all the time, well, I have plantar fasciitis. Well, a lot of times that can be something called Achilles tendinitis. It could be something called a bursitis, which is an inflamed bursa. You could have some type of a ligament tear or something else with some of the other tendons. So just because you have pain in the heel doesn't always mean it's plantar fasciitis.
So what is the telltale sign of plantar fasciitis?
Well, the telltale sign for me as a doctor, basically I push right on the bottom of the heel, right on the inside, and if you're jumping out of the chair, for me that's the telltale sign that you have plantar fasciitis. What you're going to find as a patient, the telltale sign is getting up and having pain that gets better as you walk a little bit, and then it gets worse again as you sit down. That's going to be the telltale sign. So it'll be different. We use some imaging techniques to look at the plantar fascia. A lot of times we can get an X-ray, ultrasound, or an MRI. The X-ray, in the past, it's good to see, is there any stress fracture in the heel bone, or is there a bone spur? But the bone spur isn't the problem. That's a big misnomer, where people would go to their doctor, they get an X-ray, and they see they have a big bone spur. Not everyone with a bone spur has plantar fasciitis, and not everyone with plantar fasciitis has a bone spur. And so you can't go just based on the bone spur. The next test we do is a diagnostic ultrasound, where we can actually measure the thickness of the fascia. And when we measure that thickness, that's a pretty good sign when you look at the normal levels, and if yours is thicker, it probably means there's areas of inflammation and pain in the bottom of the heel that have caused that. And then really the best way, if there's a tear or an inflammation, would be an MRI. An MRI would have fluid uptake, which basically means there's inflammation in that area, extra water, and that would show up in an MRI, and that would indicate either a tear or inflammation of the plantar fascia. It can also show thickening of the fascia as well. So those are some of the exams that we use.
Do you perform all of these exams on all of your patients?
No, we don't do it on all of our patients. Most patients, we do get an X-ray just to see if there's a bone spur, if there's any other problem. More so, I think, because of habit, or I think in our society we're kind of practicing medicine and protecting ourselves as physicians. And for example, how many times when I see a bone spur, is it really going to change my treatment? It's not really going to change. But when I look at an X-ray, I'm not just looking for the bone spur. I'm going to look to see how pronated or how flattened your foot is. I'm going to be looking at different areas of arthritis in your foot. I'm going to be looking at different other problems. So the X-ray, even though it's not specific that I'm looking just at the heel, there's a lot of other things in the X-ray that I'm looking at. An ultrasound, what I usually do with an ultrasound is I start treatment, whether it may be a cortisone injection, icing, anti-inflammatories, and if it doesn't get better in a normal amount of time, 2 weeks, 4 weeks, 6 weeks, then I'll do a diagnostic ultrasound to measure the thickness. And a lot of times that thickness can indicate there's more of a chronic issue with the plantar fascia. The ultrasound I do very rarely. The only reason I would do an ultrasound is if I'm concerned that someone has a rupture, plantar fascia rupture, which is basically a tear of the fascia. And for those that are kind of watching, the tear of the plantar fascia is basically the same as the surgery. So if you tear through your fascia, if the fascia is like this and it has a tear in it, that's the same as something called a plantar fasciotomy, which is where you cut right through the plantar fascia, and it has a tear in there. And so if you do have a tear in your plantar fascia, you've almost done the surgery for yourself. What would indicate, why would you get a tear? Well, some people just, the thing is so tight, it's so thick, it's been so many months and years, you can get a tear. But the bigger reason is if you have a lot of cortisone injection. You do 3, 4, 5, 6, and I tend to recommend 3 per year. It's not a magic number, but if you do a whole bunch of them in that area, it can slightly weaken the fascia. Beyond reducing the inflammation, it can weaken the fascia and cause a tear or a rupture of that plantar fascia.
And do patients see pain in any of these treatments?
The diagnostic treatments?
Yes, with the cortisone injections.
Okay, yeah. And that's the big concern that everyone comes in. They said, you know, my friend had a cortisone injection, and they said it was the worst injection ever. It was worse than giving birth. In my opinion, of all the treatments that I do, I think the cortisone injection is the most painful. We use a few things that can help it. We use a little bit of cold spray. It's a kind of a freezing spray on your skin. And I had a question last week. Someone asked, well, how come you don't use the EMLA cream like the dentists, right? The dentists, they put this little cream on your buccal mucosa, and it can numb it up. The problem with the foot skin is that the skin is so thick you can't put something topically to numb it well enough. I use a cold spray, and it only lasts about 5 or 10 seconds, but it is a little bit painful. There is another treatment that we do that's a little bit painful. It's something called the Graston technique. It's not specifically that we do. It's something that the physical therapists do. It's where they take a hard piece of metal and they rub down the back of the calf. And for those of you that are watching, all these pictures, we're going to put a little link on the bottom of this video. It's going to have a link to this little book on plantar fasciitis for anyone that would like to look at some of the images that we're kind of referring to that are in this book.
Now, I've just talked about the pain of the treatments. What is the pain in plantar fasciitis? Is it something that affects you on a daily basis? Is it something that can come back? Mm-hmm.
Most people with plantar fasciitis have pain every day. Most people have it when they get up in the morning. As they're active, they might be pain-free. As they sit down and then get up again, they're going to have pain. As it progresses, as it gets worse, that pain may just go throughout the whole day. And what I find is so common, people try to buy one pair of shoes, then another pair of shoes, then another. They're spending a lot of money on 10 or 15 shoes and inserts and all these things. And I always say, if you've tried 3 or 4 pairs of shoes and inserts, the problem probably isn't the shoe or the insert. The problem is your foot. You need some help. Don't go spending more money. People tend to have pain. How does it start, though? The way it usually starts is you didn't have any pain. And then one day you get up and you say, oh my goodness, what happened when you get out of bed and it hurts a lot? And you try to think back on what you did. And then most people try to take some anti-inflammatories like Motrin or ibuprofen. They try to ice it and see if it'll get better on their own. If it doesn't get better within a reasonable amount of time, and what I consider reasonable is a week or 2, you should go see someone. Because it's very common that people come in, they've had it for 6 months or they've had it for a year, and they've just been kind of dealing with the pain on a daily basis. And it's not a pain that you want to deal with, because it can hinder playing with your kids, it can hinder work, it can hinder wearing boots and things like that if you have a job that's very physical.
And once you've had plantar fasciitis, you've gone through your cornerstone extractions, you've gone through your x-rays, you've gone through your MRIs, can this pain come back?
So once it's healed, can it come back?
Yes.
Yes, it can. Of all the people that I treat with plantar fasciitis, when does it come back? It normally comes back, if it's going to come back, probably maybe there's a couple of time frames you have to think about. The first time frame is where it's really not resolved, but it's only under the treatment of the cortisone. So if I give you a cortisone today, you may be pain-free. You may be pain-free for 2 to 3 months. If in 2 to 3 months that pain comes back, I didn't really resolve your plantar fasciitis. What I did is I reduced the inflammation. So in 3 months, it may come back if you don't do anything else. That's where, when I treat plantar fasciitis, I recommend reducing the inflammation, and cortisone injection is one of those, stabilizing the foot, and then loosening up the back of the calf. Those are the 3 kind of treatments that we do. And so but let's say you do the cortisone, and after you get 6 months or a year out of the cortisone and all the other treatments, and you're doing everything right, then I find pretty much you're healed or you're better. One of the treatments that we can evaluate, one of the diagnostics exams, is a diagnostic ultrasound. And if we do that and we find that there's a lot of thickness in your fascia, then we kind of think, well, you're at a greater chance of getting it again. If if it's very, very thick, because it shows that there's some type of scarring. What happens is when an area of your body is inflamed for a long time, it actually gets thickened. It develops some scar tissue in there. And so I can treat some of your inflammation and pain, but then it may come back. It may be a year, it may be 2 years, it may be 3 years, but usually there is an incident that causes it when it comes back. And usually that incident is either weight gain, a bad shoe, going on vacation, doing a lot of walking, doing a 5K walk when you're not used to it, and things like that. There's usually some type of inciting event to have it come back. It won't just come back in a couple years if it's been treated properly.
So what can you do at home once you've had a cortisone?
There's a lot of things. So let's say, well, first of all, we can talk about what are things you can do before you go and see the doctor. We can talk about that. So the first thing we want to look at is reducing the inflammation. So to reduce the inflammation, you can take a bottle of water, put it in the freezer, and you can roll it on the bottom of the foot. You can do that. If your doctor allows you, you can take some type of a Motrin or ibuprofen or Aleve. That's an anti-inflammatory. That sometimes can help. Those are some things that you can do to reduce the inflammation. You can also support your foot. You can do a nice running shoe, a nice stable shoe, first thing out of bed. So put that on first thing out of bed in the morning, or a sandal with a nice arch support. There is a nice sandal out there called OOFOS, OOFOS. It has a nice arch support. It's very, very good for patients. There are different types of shoes that have nice stable arch. You should be seen probably at a very reputable shoe store to evaluate your gait or how you walk. Do you pronate? Do you flatten out? Do you have a high arch? Do you have a normal foot? And then finding an appropriate shoe. And I always say, if your shoes, your athletic shoes, are over 6 months or over a year old, it's time to swap them out. Even though you don't wear them that often, it's important for you to swap out those. So that's going to help stabilize your foot. If you want, you can try an over-the-counter insert. The one thing you have to realize, though, when you're trying an insert, get one that's a little bit more rigid. I find that rigid is more beneficial. If you take something like let's say this paper is the arch here of it, right here. See this? This is the arch of your orthotic. And if you can push this down with your finger, it's not really doing anything. What you need is something that's in the arch of your foot, and you try to push it down, it won't go down, so it's going to actually support your body. So that's something that's very important. If you look at a lot of these, that if you just push them down with a few fingers, they're not really doing anything for you. So that's going to be stabilizing the foot. And then the third thing is going to be reducing the tightness in the back of the calf. So trying the stretching exercises. If you have a foam roller, do some foam rolling in the back of the calf and different things like that. Those are things you can do at home. Then the next step would be, well, what happens if you go to the doctor and they give you a cortisone injection? What you can do? What can you do next? In my opinion, the three most effective ways of treating plantar fasciitis are, and these are things that a doctor would do, because you're going to try the other things before you go see a doctor. I think it's a cortisone injection, a custom orthotic that's going to be made just for you, and then physical therapy. I think these three work really well. People say, well, why do I need physical therapy? Well, it keeps you accountable. I think we're many times more accountable to a total stranger than we are to ourselves, especially when we're talking about getting treatment. So they're going to tell you what to do. They're going to monitor what you're doing, making sure you're doing it the right way so you're not going to get injured. A custom orthotic. Why custom orthotic? I just find that people that have custom orthotics, they get better faster and they can prevent recurrence if your foot needs it. Now, not every foot needs a custom orthotic. Some people don't have a lot of pronation. They don't have flattening. They don't have any other problems, so you could just do a normal shoe. And then the third thing would be a cortisone injection. I find cortisone is very helpful. I have some people, they come in and they, like, doctor, I'll do anything but cortisone. And usually they're concerned about which kind of makes sense. But if I could say, if I could only have, and I did a video about this recently, if I could only have one treatment at all for plantar fasciitis, what would that be? What that one treatment would be? If I could only do one treatment. And that treatment would be an ultrasound-guided cortisone injection. If I could only have one thing. Ultrasound guided, because you're using an ultrasound to make sure you get it right in the proper place, and you're going to do a cortisone injection, and it has a very high chance of taking away your pain.
And so you've mentioned one of the symptoms of plantar fasciitis being pronation. What is pronation?
Okay. So pronation, a lot of people think of pronation as flat feet. So when you look at your foot, when you get out of the pool in the summertime, and you see your foot flat on the ground, and you can see your whole footprint, that would be pronation. If you have a nice arch, then your foot wouldn't be as pronated. Another thing that people see sometimes is that when they look at their feet, the feet can go to the outside. That's called the too many toe sign. So when you're watching, everything kind of flattens in the ankle region, and that is pronation. And when your foot pronates, or when your foot is flat, what happens? Well, it makes your tendons have to work harder. And if those tendons are having to work harder, it's going to put more strain on the plantar fascia, because the plantar fascia isn't supposed to bear the weight of your body. It's what we consider a secondary support structure. So the primary support structure of your feet are first of all, the bones. So the bones, the way that they're connected, if they're in the proper alignment, they're going to give your foot support to take the work off the tendons. And the second thing are the tendons and the muscles that are inserting into the bones. And if your bones are working well and they're in the proper alignment, and if your tendons are working well, most likely you won't have a problem unless you overdo it. But let's say your bone structure is such that there's like a lot of sagging in the middle of the foot, or there's arthritis or other problems, and your tendons are having to work, they're having to pull a lot more, and they're getting tight. Well, if they're getting tight, then you're going to walk differently, and that can put extra strain through the plantar fascia.
Now, if any of you guys have ever been to the doctor's office, you know that they look at your medical history, and I know same thing goes for plantar fasciitis. Is pronation something that you look at in the medical history? If so, what else do you look at?
Many patients, they're not sure. In terms of most primary care doctors, they're going to say, well, you have flat feet. That's what they're going to say, and that's fine. Now, the question is, does everyone with flat feet have plantar fasciitis? No. People with really, really flat feet, they're some of the best runners. So not everyone with plantar fasciitis, not everyone with flat feet has it, or pronation has it. But it tends to be more common in those that I see. They have some flattening in the feet. So when you look at certain conditions in your medical history, can I say that diabetics get it more, or men get it more, or women get it more, or people with high blood pressure get it more? You can't say anything about other medical conditions, people that have rheumatoid arthritis. There's no correlation between other diagnoses, except, and we talked about this a little before we started, because of the weight gain with pregnancy, I see a little bit more plantar fasciitis with those that are pregnant, because of the weight gain and because of the swelling, and many times you're just very uncomfortable, and so you're wearing the most comfortable shoe, which is usually a flip-flop, and you're doing all this walking, and it can make you a little bit more prone. And that's another question that I get. Well, if I have plantar fasciitis and I'm pregnant, what type of treatments are there? Well, you still can. If you do a cortisone, it can stay right in that direction. So it's safe enough to have these treatments when you're pregnant. But the better way to start is with maybe some shoes that have a little bit more stretch, because you tend to be more swollen when you're pregnant. But pregnancy can bring on some plantar fasciitis.
And how common is plantar fasciitis in women that are pregnant?
I don't think it's that common. Or they're not coming in. Mm-hmm. Because in a typical year, I may see 1 or 2 females that are pregnant with plantar fasciitis. So it's not a lot of what I'm seeing, but many of them, they may have it, but they don't see anyone about it. I think you're just going to be uncomfortable in general. You're going to have foot pain. And another thing that can happen with the pregnancy as well is that during pregnancy, you release certain hormones during birthing. One's called relaxin, where it relaxes all the ligaments. And some people, they can relax even the ligaments in the foot, so your foot size might get a little bit bigger. It could flatten out and things like that. There are some other issues with pregnancy as well.
So can hormones tie into plantar fasciitis?
I don't know. Like, people are on hormonal treatment or things that I don't think there's a lot of hormonal causes of plantar fasciitis. I don't think so. That's a good question, though.
And so another cause that you said of plantar fasciitis could be weight gain, and so you brought up intermittent fasting. So how do intermittent fasting and plantar fasciitis connect to each other?
Yeah, if you see me in the office, I talk a lot about intermittent fasting with my patients, and this is all the craze these days, and everyone thinks it's crazy. Basically, intermittent fasting is going through periods of time where you don't eat, and I'm not saying that intermittent fasting is good. It's not going to cure your plantar fasciitis. I'm not saying that. There's no research to show that. But if one of the problems is weight gain, well, let me kind of explain. When people come into my office, they're trying to get in shape. The majority of people that come in for plantar fasciitis is because they start working out and they're wanting to get in shape, and they're doing an exercise regimen that cause their foot to start to hurt. And I see this with a lot of foot conditions, not just plantar fasciitis. And so they're trying to exercise to lose weight. And I have a conversation with them a lot of times. If the desire is to lose weight, I think it's much more beneficial to do intermittent fasting as a way to lose weight versus exercise. Exercise has great reasons mentally, has endorphins that it produces. It makes you feel good. I think exercising is great. But really, to lose weight, intermittent fasting tends to work well. There are a couple of good books out there. There's a lot of videos you can watch on YouTube and things like that. But basically, intermittent fasting is a period of not eating. Okay? And basically, in our society, we used to eat our last meal at 5 p.m. and our first meal at 8 a.m. And so we had that window from 5 p.m. until 8 a.m. as a period of fasting. What's happening now in our society is that we have more eating opportunities. We're snacking. We have our breakfast, then we have our mid-afternoon snack, then we have our lunch, then we have our little snack in the afternoon, then we eat our dinner, and then we have our ice cream before we go to bed. And all these eating opportunities, they affect our insulin levels, which our insulin levels are going up higher, and that's going to be the main cause of weight gain. And if you do a greater window of not eating with intermittent fasting, I always tell my patients, both my patients that are diabetic and those that are trying to lose weight, it's a much more effective route. Now, I'm not a diet doctor, so I refer them to the other appropriate doctors that they can see, nutritionists and things like that.
And so my last question for you is, does plantar fasciitis run in families?
How many, children of mothers do I see with plantar fasciitis? I think it's virtually none. I don't see mother-daughter or sons. I don't see that as a cause. Possibly because of your body type, you might see it if in their activity level you could see it a little bit, but I don't find it's caused. Just because your mom has plantar fasciitis doesn't mean that you're going to get plantar fasciitis. Now, just because your mom has a bunion, you're going to be more likely to get a bunion, but not plantar fasciitis. That's good. Well, thank you. Thank you for coming and helping with the interview, and thank you for all that are watching this episode of Healthy Living.